Welcome to the deep dive. Today we're attempting to tackle a huge topic.
Yeah, it's pretty massive. We're diving into the circulatory system.
Specifically blood flow, blood pressure regulation,
Yeah,
and, what happens when things go wrong.
exactly. Our guide here is Porth's Pathophysiology. The mission is really to walk you through how vessels are built, how pressure is kept in check, and then connect all that directly to, well, the common problems you see: arterial issues, venous issues, pressure going haywire.
So you can see the symptom and kind of picture the mechanism behind it.
That's the goal. Link the textbook stuff to the real-world clinical picture.
Okay, let's start at the foundation then, the structure. I
Hmm.
mean, the scale is just mind-boggling when you think about it. Like 60,000 miles of vessels.
Incredible, isn't it? And most of them, except for the tiniest capillaries, share this basic three-layer design, these tunicae.
Right, the tunicae, you've got the outer layer, the tunica externa,
Hmm.
sort of the supportive wrapping.
Yeah, connective tissue mostly. Then the middle layer, the tunica media, that's the muscle layer, the powerhouse.
And inside, facing the blood, is the tunica intima, which is basically that crucial endothelial lining.
Precisely, and the capillaries, where all the real exchange happens, nutrients, gases, they streamline everything.
They're just that single layer of endothelial cells, maybe with a few supporting cells called pericytes scattered around. Super thin, super efficient.
And that endothelial lining, that intima, it's way more than just a smooth pipe. It's like this incredibly active organ.
Organ, really.
Absolutely. Think about its jobs. It's a filter, controlling what gets in and out. It manages clotting, whether platelets stick or not. It actively changes blood flow by tweaking resistance. And it's central to inflammation.
Wow. Okay, so if that lining gets damaged or irritated, maybe from high blood pressure, constantly pounding on it, or smoking, or high cholesterol, that's endothelial dysfunction.
That's exactly it. The cells literally change. They become less non-stick. They start putting out inflammatory signals, cytokines, and they start messing with the muscle cells underneath them, the SMCs.
The vascular smooth muscle cells. In the tunica media, those are the ones that actually squeeze or relax the vessel, right?
Yep. They respond to signals like norepinephrine from the sympathetic nerves. Norepinephrine hits them, they contract, vessel gets smaller, resistance shoots up.
But they do more than just contract, you mentioned.
Right. They're also kind of the vessel's construction crew. They make collagen and elastin. But here's the catch. When there's injury, they can go rogue. They start migrating into that inner layer, the intima, and multiplying.
And that abnormal migration, that's bad news.
It's a huge part of the story in things like atherosclerosis, really central to how those plaques start forming.
Okay, that structure, the muscle control, it sets the stage for regulating blood pressure system-wide,
Exactly. And to regulate it, you got to measure it first. We use a few key terms.
like systolic pressure, the peak pressure when the heart contracts. Ideally, below 120?
Ideally, yes. And then diastolic pressure, that's the lowest pressure when the heart relaxes between beats. Should be under 80.
And the difference between systolic and diastolic, that's the pulse pressure. Tells you something about how spermy your arteries are, I guess.
It does. But the number clinicians often watch most closely for actual tissue perfusion is the mean arterial pressure, or MAP.
The average pressure driving blood forward, usually around 90 to 100 millimilli.
That's the typical range. And if you think about the physics, MAP is determined by two main things: how much blood the heart pumps out, that's cardiac output, CO up.
Which is heart rate times stroke volume.
Right. And how much resistance that blood encounters in the system, peripheral vascular resistance, PVR. So MAP equals COX PVR. It connects the pump and the pipes directly.
Okay, so when things change fast, like you jump out of bed or sprint for a bus, the body needs quick fixes, right? Seconds to minutes.
Absolutely. That's where the neural reflexes and some quick-acting hormones, the humoral responses, come in.
Neural control. That's the brainstem, the cardiovascular center.
Yes, medulla and pons. It uses the autonomic nervous system. But the classic example, the reason you don't faint when you stand up, involves the baroreceptors.
Ah, the pressure sensors in the neck and aorta. The carotid and aortic sinuses.
Exactly. Think of them as stretch detectors. You stand up, gravity pulls blood down, pressure drops up top, so the baroreceptors sense less stretch.
And they send an immediate alarm signal.
Instantly. Signal goes to the brainstem, which ramps up sympathetic output, heart beats faster, vessels constrict, and boom, pressure comes back up. It's incredibly fast. And then you have chemoreceptors nearby too. They're mostly watching oxygen, CO2, pH levels.
So more for emergencies.
Yeah.
Like if oxygen plummets.
Yeah, or if blood pressure drops really critically low, they can trigger widespread vasoconstriction to try and save the brain and heart.
Okay, that's the nerves. What about the chemical signals, the humoral side? The RAAS system seems huge here.
Oh, it's fundamental. The renin-angiotensin-aldosterone system. If the kidneys sense low pressure, low blood volume, or even just high sympathetic activity, they release renin.
And renin kicks off a chain reaction.
It does. Renin leads to angiotensin the first. Then, an enzyme called ACE angiotensin converting enzyme, found mostly in the lungs, interestingly, on those endothelial cells.
Converts angiotensin the first to angiotensin the second.
And angiotensin the second is the real workhorse here. It's incredibly potent.
How so? What does it do acutely?
Two big things immediately. One, it's a powerful vasoconstrictor all over the body, so it directly increases PVR, jacks up the pressure.
Okay.
Two, it tells the adrenal glands to release aldosterone. Aldosterone then tells the kidneys to hang on to salt and water. That helps increase blood volume, which also raises pressure, but that's more of a slightly longer-term effect compared to the instant vasoconstriction.
So RAAS is like the body's pressure rescue system, hitting both resistance and volume.
Pretty much. You also have vasopressin, or ADH, antidiuretic hormone. It gets released if volume or pressure drops too low, and it also acts as a vasoconstrictor and makes kidneys conserve water.
And adrenaline, epinephrine, that's in the mix too.
Yep. Catecholamines like epinephrine and norepinephrine released from the adrenals also increase heart rate, contractility, and cause vasoconstriction, all adding up to raise BP quickly.
But all these rapid responses,
Yeah.
they can't run forever, can they? What about long-term control?
For the long haul, it really comes down to the kidneys and their control over your total body fluid volume.
How does that work? It seems almost too simple.
It's elegantly simple, really. If your blood pressure drifts too high, maybe you ate a ton of salty food and retained water, that higher pressure literally pushes more fluid through the kidneys.
And the kidneys respond by?
By excreting more water, that's pressure diuresis, and more salt, pressure natriuresis. So you pee out the excess volume, blood volume drops, and pressure comes back down. It's a direct link between fluid volume and long-term pressure.
That makes sense. Volume goes up, pressure goes up, kidneys dump volume, pressure comes down.
And interestingly, that increased volume initially raises cardiac output, but over time, the body's local tissues auto-regulate, constricting vessels if they get too much flow, which also contributes to raising peripheral resistance long-term. It's interconnected.
One quick clinical point here. You mentioned timing. What about blood pressure changes during the day?
Right, circadian variations. Normally, your blood pressure should take a dip at night while you sleep, maybe 10% to 20% lower than your daytime average. We call that nocturnal dipping.
And if it doesn't dip?
If someone's a non-dipper, their pressure stays high overnight. That's actually a significant warning sign. It predicts a higher risk of heart attacks, strokes, and other cardiovascular problems down the road. Something to watch for.
Okay, good point. Now, let's pivot from how things should work to how they break. Disorders of arterial blood flow.
And the bottom line with arterial disease is usually ischemia. Not enough oxygen getting through. If it's bad enough or lasts long enough, you get infarction tissue death.
And a major driver behind a lot of this is dyslipidemia, right? Funky lipid levels in the blood.
Absolutely. We're talking triglycerides, phospholipids, but mainly cholesterol. Cholesterol doesn't just float around free. It's carried in packages called lipoproteins. We classify them by density.
VLDL, LDL, HDL.
Exactly. LDL, low-density lipoprotein, gets the bad rap as bad cholesterol. Why? Because it's the main transporter delivering cholesterol to the body's tissues.
But how the body gets rid of LDL is crucial, isn't it?
Very. Normally, about 70% is cleared efficiently by specific LDL receptors on cells, especially liver cells. Think of it as the designated recycling pathway.
But if that pathway is overwhelmed or genetically broken?
Like in familial hypercholesterolemia, where people are born with faulty or missing LDL receptors, then the body uses a backup plan, the scavenger pathway. Macrophages start gobbling up excess LDL.
But not just any LDL.
Critically, they mainly take up oxidized LDL, LDL that's been chemically modified, damaged. When macrophages eat too much of this oxidized LDL, they transform into these big, bloated cells called foam cells.
And foam cells are bad news.
They're basically the building blocks of atherosclerotic plaque. That scavenger pathway, meant as a cleanup system, becomes central to the disease process itself.
Okay, so LDL delivers cholesterol to tissues, can get oxidized, eaten by macrophages, becoming foam cells. What about HDL, the good cholesterol?
HDL, high-density lipoprotein, does the opposite. It facilitates reverse cholesterol transport. It picks up excess cholesterol from tissues, including from those foam cells, and carries it back to the liver to be processed and eliminated.
So it's cleaning up the mess.
Essentially, yes. It's thought to be protective, maybe also by reducing oxidation and inflammation.
Which brings us squarely to atherosclerosis, hardening of the arteries. these fibrofatty lesions building up inside the vessel walls.
Primarily in the intimpotted portions of large and medium-sized arteries. And the risk factors, they don't just add up, they multiply.
Yeah, you mentioned high cholesterol's key, especially high LDL. But things like high blood pressure, smoking, diabetes, age, being male,
Yeah.
they all play a role.
And the synergy is frightening. You said it earlier. Hypertension plus diabetes alone can increase atherosclerosis risk maybe 8 times. Throw in high lipids and smoking, the risk skyrockets, like potentially 20-fold or more compared to someone with no risk factors.
Wow, so how does the plaque actually form? Walk us through the steps.
It starts with injury to that delicate endothelial lining. Could be from sheer stress from hypertension, toxins from smoking, high glucose, high LDL. Step 1 is damage.
Okay, the lining's hurt. Then what?
Step 2, inflammation kicks in. White blood cells, specifically monocytes, get sticky, attached to the injured area, and squeeze through into the intima. Once inside, they transform into macrophages.
This is cells that eat stuff.
Right. Step 3, those macrophages start eating the oxidized LDL we talked about, turning into foam cells. This accumulation of foam cells is really what drives the lesion growth early on.
So you get this growing pile of fatty macrophages.
Exactly. Step 4, plaque development. Other cells get involved, like those smooth muscle cells migrating in. They produce matrix, collagen, forming a fibrous cap over this core of lipids and foam cells. That's your classic fibrous atheromatous plaque. Looks kind of grayish-white.
But the real danger isn't always the stable plaque itself, is it? It's when it becomes unstable.
Precisely. Step 5 is the complicated lesion. This is where the plaque ruptures or ulcerates. If that fibrous cap covering the lipid core is thin and weak, and the core underneath is large and soft, we call that a vulnerable or unstable plaque.
And if it ruptures?
It exposes all that highly thrombogenic material, lipids, tissue factor, directly to the flowing blood. That triggers massive sudden clot formation thrombosis right on top of the plaque. That's what usually causes the heart attack or stroke, the acute event.
So plaque rupture leading to thrombosis, that's the killer complication.
By far the most important one.
Okay, beyond atherosclerosis, there are other arterial issues, like vasculitis.
Yeah, vasculitis is basically just inflammation of the vessel wall itself, sometimes leading to necrosis or tissue death within the wall. There are many types.
Any common examples?
A classic one, especially in older adults, is giant cell temporal arteritis. It often affects arteries branching off the aorta, like the temporal artery in your head. It's thought to be autoimmune. Patients might suddenly get a severe headache, jaw pain, sometimes vision problems.
And when arteries in the limbs get blocked.
We see distinct patterns. If it's sudden acute arterial occlusion, maybe from a blood clot traveling from the heart, an embolus, or forming locally, a thrombus, it's a surgical emergency.
How would that present?
Classically with the 7 Ps. Pistol shot onset, sudden, pallor, pale skin, polar cold, pulselessness, no pulse downstream, pain, severe, paresthesia, numbness or tingling, and eventually paralysis. You need to restore flow fast.
That sounds traumatic. What about the slower chronic version?
That's peripheral artery disease, or PAD. This is usually due to atherosclerosis gradually narrowing the arteries, most often in the legs.
And the main symptom people notice?
Intermittent claudication. It's pain, cramping, or aching, typically in the calf muscle, that reliably comes on with walking a certain distance and goes away completely when they stop and rest.
Why the calf? And why only with walking?
The calf muscles need a lot of oxygen when you walk. If the arteries supplying them are narrowed by plaque, they just can't deliver enough oxygenated blood to meet the demand during exercise. The pain is the muscle basically crying out for oxygen ischemia. Rest reduces the demand, pain goes away.
And the PAD gets really bad.
The pain can start happening even at rest, especially at night when the legs are elevated. You might see skin changes, ulcers that don't heal, and eventually even gangrene requiring amputation.
Okay, one more arterial issue, Raynaud's. That's different, right? Not plaque.
Right. Raynaud disease or phenomenon is about intense vasospasm. The arteries clamp down excessively, usually in the fingers and toes, often triggered by cold or stress.
What does that look like?
It causes characteristic color changes. First, the fingers turn white, pallor, because blood flow is cut off. Then they might turn blue, cyanosis, as the trapped blood loses oxygen. Finally, when the spasm releases and blood rushes back in, they turn bright red, hyperemia, often with throbbing or tingling.
Okay, let's shift gears slightly. Aneurysms and dissections. Still arteries, but a different kind of structural failure.
Exactly. An aneurysm is an abnormal localized bulge or dilation in a blood vessel wall. The wall gets weak and balloons out.
Are there different kinds?
Yeah, a true aneurysm involves all three layers of the vessel wall bulging out together. A false aneurysm, or pseudoaneurysm, is more like a leak where blood escapes through a hole in the inner layers but is contained by the outer layer or surrounding tissue.
And a dissecting aneurysm.
That's actually a bit different, often called an aortic dissection. It's not just a bulge, it's a tear in the intima, the inner lining. Blood surges through that tear and starts splitting or dissecting the layers of the vessel wall apart, creating a false channel within the wall itself.
That sounds incredibly dangerous.
It's an acute, life-threatening emergency. Usually happens in the aorta. The main symptom is sudden, excruciating pain, often described as tearing or ripping, typically in the chest or back.
What causes the wall to tear like that?
Major risk factors are chronic hypertension, which puts constant stress on the aortic wall, and conditions that weaken the tunica media, the middle layer.
Okay, switching sides now, the venous circulation, these are low-pressure vessels, right? Different problems.
Very different. Veins are thinner-walled, more distensible. Their main challenges are blood pooling, stasis, and valve failure, leading to backward flow, insufficiency. They have to fight gravity to get blood back to the heart.
How do they normally manage that?
Two key things.
Yeah.
One-way valves inside the veins prevent backflow, and the squeezing action of surrounding skeletal muscles, the muscle pump, milks the blood upward when you move.
So if you stand still for a long time, or the valves get leaky?
You get problems. Varicose veins are the common result, those dilated, twisted, superficial veins, usually in the legs, caused by prolonged standing, increased pressure stretching the veins, and valve incompetence.
And if that venous backup becomes chronic and severe?
That leads to chronic venous insufficiency, basically persistently high pressure in the leg veins. This forces fluid out into the tissues, causing edema, congestion.
Doesn't it cause skin changes too?
Yes, characteristically a brownish discoloration of the skin, especially around the ankles. That's from hemosiderin iron pigment leaking out from broken down red blood cells that have been forced out of the congested capillaries.
And in the worst cases?
You can get stasis dermatitis, inflammation, and breakdown of the skin, and eventually venous ulcers. These typically occur around the ankle area and are notoriously slow to heal because the underlying tissue is so unhealthy due to the chronic congestion. They're actually the most common cause of lower leg ulcers.
Okay, veins can get insufficient. They can also get blocked by clots, right? DVT.
Deep vein thrombosis. Clot formation in the deep veins, usually the legs. Very common, especially in hospitalized patients or anyone immobile for long periods.
What causes these clots to form?
It comes down to the classic Virchow's triad. 3 factors increase risk. Stasis. Blood flow is sluggish, like during bed rest or long flights. Hypercoagulability. The blood itself is more prone to clotting, maybe due to genetics, cancer, or certain medications, and vessel wall injury, damage to the vein lining, perhaps from surgery or trauma.
And the big danger with DVT isn't usually the leg itself, is it?
No, the major, potentially fatal complication is that a piece of the clot breaks off, travels through the bloodstream, and lodges in the pulmonary arteries and the lungs. That's a pulmonary embolism, or PE.
Okay, last major area. Disorders of blood pressure regulation itself. Too high or too low? Let's start with hypertension.
Sustained high blood pressure. The vast majority of cases, like 90–95%, are primary or essential hypertension.
Meaning we don't know the exact single cause.
Right. It's likely a complex mix of genetics, lifestyle factors, obesity, high salt intake, stress, lack of exercise, age, ethnicity. Lots of contributing factors, but no one identifiable underlying disease.
And the other 5–10%.
That's secondary hypertension, where the high BP is caused by another specific condition. Things like kidney disease, certain adrenal gland tumors releasing hormones, thyroid problems, even coarctation of the aorta, which is a narrowing. If you treat the underlying cause, the BP often improves.
But whether it's primary or secondary, the real danger of long-term hypertension is
Target organ damage. Chronically high pressure batters sensitive organs. The heart has to work harder, leading to left ventricular hypertrophy and eventually heart failure. The kidneys get damaged, nephrosclerosis leading to chronic kidney disease.
brain and eyes too.
Absolutely. Hypertension is a major risk factor for stroke, both ischemic and hemorrhagic, and also contributes to cognitive decline and dementia. In the eyes, it causes hypertensive retinopathy, damaging the small blood vessels, which can impair vision and even lead to blindness.
It really highlights why controlling BP is so critical, even if people feel fine. Clinically, how is it defined now? The threshold changed recently, didn't it?
Yes, the 2017 ACHE guidelines lowered the bar. Stage 1 hypertension is now defined as a systolic pressure of 130 to 139 mmHg OR, a diastolic pressure of 80 to 89 mmHg HGOR. Elevated BP is 120, 129 systolic, and less than 80 diastolic. Normal is below 20/80.
Okay, lower thresholds mean more people are diagnosed, hopefully leading to earlier intervention. Now, what about the opposite problem pressure that's too low, specifically when changing position?
Orthostatic hypotension, also called postural hypertension. It's defined as an abnormal drop in blood pressure when you stand up.
How much of a drop?
Typically, a fall of at least 20 mmHg in systolic pressure or at least 10 mmHg in diastolic pressure within 3 minutes of moving from lying or sitting to standing.
What's happening physiologically there? Or rather, what's failing to happen?
When you stand, gravity immediately pulls about 500 to 700 milliliters of blood down into your legs and abdomen. This momentarily decreases venous return to the heart, lowers cardiac output, and drops blood pressure.
But normally the body corrects that instantly.
Yes, the baroreceptors sense the drop and trigger that rapid reflex increase in heart rate and vasoconstriction we talked about earlier. Pressure should stabilize within seconds.
So in orthostatic hypotension, that reflex is failing somehow.
Exactly. The compensation is inadequate or too slow. Why might it fail? Several reasons. Maybe blood volume is low to begin with dehydration or taking diuretics. Certain medications can interfere with the reflex.
What else?
Prolonged bed rest makes the reflexes sluggish. Aging itself is a big factor. Baroreceptors become less sensitive, arteries get stiffer, and underlying autonomic nervous system disorders like those sometimes seen in diabetes or Parkinson's disease can directly impair the reflex arc.
And the main consequence is feeling dizzy or fainting.
Yes, symptoms range from lightheadedness or dizziness to blurred vision, weakness, and syncope or fainting. It's a major cause of falls, especially in older adults, which can lead to serious injuries.
Wow. Okay, we really covered a lot of ground there. From that single layer of endothelial cells all the way to systemic pressure failures and organ damage, it really drives home how interconnected everything in the circulatory system is.
It really does. Structure, function, regulation, disease, it's all linked.
Yeah.
And maybe a final thought for you to take away. Really internalize that synergistic effect of risk factors we mentioned.
Right, the multiplicative risk.
Yeah. Remember, having hypertension, diabetes, and high cholesterol together doesn't just add risk. It multiplies it maybe close to 20 times the baseline risk for atherosclerosis. It hammers home why understanding these mechanisms is so vital for prevention and patient education. You have to tackle all the factors.
That's a powerful point to end on. Understanding the why behind the risks is key. Well, thank you for joining us on this deep dive into the complex world of vascular health and disease. We hope this review was helpful for cementing these crucial concepts. From the Last Minute Lecture team, thanks for listening.